Is he around? Dr. Bhagat or his, no. We'll go for the next presentation. So again, Dr. Mrinal Kanti Das to be presenting on role of microcatheter in primary PCI.
Good morning, everyone, respected chairpersons and moderators. This is a small case, though there were a lot of adrenaline secretion during the procedure, but could someone help? Audio visual? So this is a 45 years male admitted with acute MI of 1 hour duration, smoker, hypertensive, and there is history of stressful life. ECG showed extensive hyperacute changes in the anterior wall with features of myocardial infarction. Echocardiography showed hypokinetic anterior, lateral, and septal walls. Tropi was positive. So this was the presentation. So we thought that since the patient came within an hour, so let us give the benefit of primary PCI and could you help? All videos, these are meant for this. Without videos, how can the cases be presented?
Videos are more important.
So an EBU catheter was engaged. Mic please. So it was engaged at LCA and there was total cutoff in the LAD, and we thought that we won't go for any thrombosuction in this particular case because of the guidelines that are there, that routine thrombosuction is rather class 3 indication. So we wanted to dilate at different levels. We put the guide wire. So this is the total cutoff at LAD. So put the guide wire, it went easily, and then we tried to dilate with the 2 by 12 millimeter balloon at different levels. But what we saw that after the injection was given, the dye was not coming. There was still a lot of thrombus, and we are not being able to determine which length of the stent can be deployed, though the usual practices are long stent can be deployed even without seeing much by dilating the proximal part of the area with the thrombus. But we thought that let us find out something since we didn't want to use the thrombosuction catheter. So we put a micro catheter, and at different levels we put the dye and found out at which level there was no occlusion. As you can see here, that at this particular point, beyond that there was no block. So we could find out the length of the stent which is to be deployed in this particular artery, and we put a long stent, and that was deployed, inflated, and after that the post-deployment this injection showed this kind of a flow. And the thing is that after the deployment as well, there was a little bit of slow flow. We gave all kinds of medications like adenosine and other things which are usually practiced like nicorandil and all. And ultimately, after the deployment of the this stent, we found that the flow was okay, and this is the final result. And the take-home message for this is that use of microcatheter may be quite handy to localize the distal part of thrombus, and the length of occlusion during primary PCI prevents unnecessary balloon dilatations, which might cause a lot of problems during the primary PCI, especially in the background of the dissection and all. And if it thus gives the idea of the exact length of the stent to be deployed. Thank you very much for patient hearing.
Very good. Actually, what is the window period at which you intervened this case, angioplasty, onset of chest pain, and
It was within an hour.
So that's why actually I'm telling the same thing. Before balloon dilatation, if you do the thrombosuction, you won't get these situations, because we face these type of problems initially, and then we'll be in dilemma. It is due to the distal embolization of thrombi, so that you won't see the landing zone. So that's why you have to see the microcatheter, and then you have to see the landing zone.
Yeah, exactly. I completely agree with you. In fact, we used to do the same kind of thing earlier as well. We used to put the thrombosuction catheter and do the thrombosuction. But somehow or other, in one or two
Definitely.
cases, we had some problems, acute,
situation,
catastrophic problems also.
Very good.
So we thought that let us follow the guideline and straight away go for the balloon dilatation at different levels, and then come out with a sort of simpler kind of treatment schedule in this group of patients. And that's why actually we didn't use the thrombosuction catheter as well, because that again is could have given
Very
another.
important, actually, to see the
So
landing
naturally
zone,
we
you are
cut down the
innovative
cost
idea.
as well as the simpler method of calculating the length of the catheter.
Right.
In such a situation, when you are putting any device down such a length, you are bound to pull back some of the thrombus along with the device into the left main and L6 also. So in such a case, I think aspirating with the thrombus aspiration and trying to figure out what is the extent, and then trying to see whether you can do some sort of deferred stenting, or nowadays you're talking about intracoronary tenectoplase. We have seen some of these cases.
All these possibilities were thought of, and regarding the migration of the thrombus, we also thought that this kind of thing might happen even in this case. That's why I put another catheter, the guide wire in the circumflex as well, and thought that we could come out easily. But somehow or other it was not going easily, taking out a lot of adrenaline from ourselves only, and then we thought that let us put this stent directly after finding out the length.
Very good. Yes.
Sir, one small tip. Sometimes it's an excellent case and very nice, this one. Just one small tip. Sometimes if the microcatheter is not available, one can take a small 2 millimeter balloon, rupture it outside, and take the balloon in up to the place where you want and inject contrast through the place where you inflate. That will also do the same thing. You can deliver drugs also through it, and you don't need to lose the wire position. So,
But you're talking of the over-the-wire balloon.
Over the wire balloon.
sir, if one takes a rapid exchange balloon and ruptures it outside, then you can
What do
take
you
the
think,
wire
Doctor?
with the rapid exchange port distal to that and inject through where you inflate. So you'll be able to see the contrast going distal. You can deliver drugs through it distal, and one doesn't lose the wire position.
So,
But air embolism is occur because our for G balloons now.
Dr. Hiram, do you think, it's going to be some standard practice, especially in lesions like this in the long run, or you try this sort of?
Drug delivery locally. No, actually I missed Mrunal's case
Not drug
completely.
delivery. This is just to find out the distal extent of the thrombus or the lesion and to figure out what is the length of this stent which you have to choose. So
I don't know what future it will have, but at least in his case it served the purpose. You know?
There is a
All right.
little concern over here that when he gave the dye from the microcatheter, there was no forward flow. There was no forward flow at that point of time. So, should we have deferred the stenting at that time? Because there was no forward flow, there was total occlusion at the distal circulation. So, the slow flow was expected.
No, the situation
Yes.
here is whether it is due to no flow phenomena or dissection, we do not know, because he dilated the balloon, we do not know what are the thing happening because of no flow. That's why in chronic total occlusion we do the same technique. Once it will pass, then whether it is a true lumen or whether due to sometimes debris become embolized, then you can give this injection. Once it means that clearly the vessel architecture will delineate it, it is easy actually. At the situation, that is one of the things actually, once there is no flow phenomena is there.
No, but the objective was to give him the TIMI 3 flow. All right. So when there is no flow at the distal circulation, actually there was no flow. Slow flow might have been
Yeah, you are very much right. There was slow flow, and for that, all the measures were taken, whatever is done in the cath lab. So we were giving adrenaline, nicorandil, then adenosine and everything. Since it was not coming back, though it has been shown with that only hardly 7 slides or 8 slides, there are a lot of more slides, but and a lot of more time was also involved. And since it was not coming back, that's why this decision was taken, and rightly pointed out by your previous speaker, that we could have used the balloon itself by puncturing. We could have done it, but we thought that let us try another method without going for puncture and all, by putting the microcatheter and using that, and to see the distal obstruction, and as well as to see whether there is really slow flow or no flow in distally or not. So that was the main intention.
Thank you, Mrunal. We need to move on. So we go to the next case, Raju Bhagwat. Okay, you're presenting for Raju.
Good morning, respected audience. At the onset, I would like to thank the organizing committee and the chairpersons for giving me the opportunity to present this case in front of you. I would be presenting a case of complex left main bifurcation. We had a 78 years old female who presented with angina. On admission, she had landed with cardiogenic shock, and her ECG showed NSTEMI. Her cardiac enzymes were positive. So now we decided to take her up for angiogram. So we started with IBPA upfront and loaded her in with inotropic support. This was her angiography. The angiogram revealed left main critical ostial stenosis and a non-dominant circ but a fairly big vessel and a dominant right circulation. So to start with the bifurcation, we initially wired both the arteries, the LAD and the circumflex, and we pre-dilated the lesion, ostial left main, with the NC balloon, followed by a cutting balloon. And this was the result after debulking the lesion. Now, the strategy in mind was to go with a provisional stenting. So for the same, we took a stent 3.5 by 12 from left main to LED. Initially, we took a bigger stent because there was some disease at the proximal LED also, but it was difficult for us to deploy the stent and take it ahead because of the ostial left main involvement. So then we took step down to a smaller stent of 3.5 by 16 in the left main to LED. But after deployment of the stent, though at nominal bars, we could see a plaque shift at the ostial circumflex. So that's why now we had to change our strategy from provisional stenting, and we had to take care of the circumflex too. So we rewired the circumflex with another wire, and then the next strategy now mine was to go with a T with protrusion tap stenting. So now for initiating the tap stenting, the second stent was took around 3.5 by 16 this Orsiro stent into the circumflex via the left main LED stent, and it was deployed there. But again, now there was another difficulty that during the deployment of the circumflex stent, the struts of the circumflex stent protruded into the left main stent, left main to LED stent. So now again on table we had to shift our strategy from tap to reverse crush. So now to initiate the strategy, we took a NC balloon into the LED and crushed internally the circumflex struts ostium. Ostial circumflex struts internal crush was done. Followed by again the rewiring was done, and the circumflex and the LED stents were individually post dilated, followed by a kissing balloon dilatation, as we could see here. And this left us with a acceptable result. Later, we managed to cross the 2.75 by 16 Orsiro inside the proximal LED and deployed there, followed by the final pot, and this gave us a good result. This was the final result, as we could see here. So the take-home message from this case that as we had a short left main in our case, so short left main is a difficult subset. There is no proper landing zone. It is obviously technically demanding. So initially in our case, we started with provisional stenting in mind and had to change to a tap because of the significant plaque shift, and ultimately landed up doing a reverse crush. Also, ostial left main lesion in a short left main is even more tricky. So this patient had significant ischemic LV dysfunction, so which was reversed on revascularization and of course the IVP support, which was taken off later. So I would say that one should be well aware of the inadequacies of the various stenting strategies, and these all strategies should be addressed successfully. Whatever it is, we need to complete the bifurcation procedure if at all we have started. Just a single last slide on the strategies to deal with a suboptimal tap if in case we come across in our lab. So what difficulty we face that two distal stent deployment may be there, we may miss the ostium. So in that case, another stent implantation can be done on the side branch ostium according to the tap. Also, the other problem can be there accidentally too long protrusion inside the main branch. More than 2 to 3 struts can be protruded into the main branch. So in such cases, what we did that has to be done, that a balloon should be advanced into the main vessel and dilated so that the protruding side branch stent struts are crushed adequately, achieving the configuration of a reverse internal crush. Also, at the very rare cases, accidentally extremely long protrusion inside the main vessel with side branch stenting reaching almost the proximal main vessel stent segment. So in such cases, the failed tap on table should be converted into a culotte technique by post dilating the proximal main vessel and then rewiring the distal main vessel in order to finish with a kissing balloon dilatation and finally the pot, which would leave us with a good result. Thank you so much.
Yeah, I think with use of stent boost, you are able to really see how much you're protruding back.
Yes, sir.
And that would allow you to convert too much protrusion into a crush, reverse crush. I think very well done. I think otherwise we could have left with too much stent protruding into the.
Yes.
See, in T with protrusion, you are creating two parallel barrels. So it must have an just adequate.
Basically, the tap technique itself, when you put a stent into the circumflex, you should have a balloon inside the LMCA to LED. That is actually tap technique. It is not tap technique what you just done. You do a T stenting, provisional T stenting, where you put a T stent and the T was protruded into the LMCA. In a tap technique, you should have a balloon from the LMCA to LED. You should have a stent there. Once the stent is inflated, you withdraw the balloon of the stent into the LMCA and both the balloons together. That is actually the simplest of the bifurcation technique, and actually you made it unnecessarily complicated.
Yeah.
No, but I'm sure
Very
you
well.
did balloon. You had simultaneous balloon in
No,
the
there
left.
was no balloon, simultaneous balloon.
There was no balloon. That was why all the complication happened.
No, but as a part of tap, when you do tap, you must have a balloon in the main branch. So you will have one stent, you pull a balloon back, and you must have a simultaneous balloon in the main
We
branch.
can make it simplified actually what.
Yeah, I got it.
So you pull and simultaneous final kissing, it will be finished at the step only.
Yes.
You need not do the second step.
But Pratap, I thought even when you do T, you bring the balloon back and have a kiss. So it's never that you don't kiss, you know, even.
Keep a balloon left.
That may
Yeah.
be the reason because of excess protrusion.
No, but audience should not go with the feeling after your comment that for T you do not need a balloon. For T also you need a balloon. But not the way it is planned.
Once you protrude means you have to do final kissing in a tap. That is the difference between T and tap.
Yes.
All right, thank you
Thank you
indeed.
so much. Thank
We
you,
move
everyone.
on to the next. Ajay Gopal. Dr. Ajay Gopal is here. Okay, we skip. We go to next. Dr. Vishwanath. Oh, Ajay Gopal? Okay, sorry about that.
Good afternoon. Thanks NIC for this opportunity. I'm presenting here a patient, a 55-year-old gentleman, diabetic for the last 5 years and is well controlled on oral hypoglycemic agent, presented to casualty with chest discomfort of 8 hours duration. In the casualty, his systolic BP was around 80 to 90, and when he reached cath lab, he was on dual inotropes and no IUBP. He was in acute pulmonary edema with a saturation of 94%, with 2 liter of O2 and intermittent BiPAP. He was not intubated. His ejection fraction was 20 to 25%. Since this was the ECG when he came to the casualty, it's showing anterior stimulation MI in junctional rhythm. We given him option of plasty as well as thrombolysis. They were not ready for thrombolysis because his neighbor has recently expired because of IC bleed post lysis. So he was in ICU, and after 5 hours of admission, he started on heparin. After 5 hours, they consented for an angiogram, and this is the angiogram. The LAD size was almost 2.5 to 2.75, and the LCX was non-dominant, and the size was less than 2 millimeters. RCA was the dominant vessel and essentially normal. So basically, anterior wall stimulation myocardial infarction in junctional rhythm, cardiogenic shock, pulmonary edema, not ready for lysis, and they gave consent for angiogram after 5 hours and found that there is a significant left main disease and they have financial constraints. They told that the bystander will ask the son who is in Gulf whether they are ready for a angioplasty. So the bystander came after 1 hour after discussing with the son and told that they are ready for an angioplasty. because they can arrange only 80,000 rupees, but make sure that the patient is alive. So we got a consent for PCI after 1 hour. The radial went into spasm and so switched to the femoral route. One wire went into LAD and the other into the diagonal. So did it with an ox balloon, dilated the ostial left vein. There is some difficulty in moving an ox balloon into the LAD, but somehow it went into the LAD, but the diagonal wire was going dangerously. But however, dilated the whole length. This is actually a 2.5 into 12 balloon. You can see the size of the LAD was almost the size of that balloon, 2.5 balloon. There is some difficulty in tracking the long stent, 2.75 into 38. So I removed the diagonal wire and positioned the stent and deployed it. So 2.75, 38. You can see that even that 2.75 stent was somewhat looking like an overexpanded for the distal LAD. So decided to post dilate the left main and ostial LAD with 3 NC balloon followed by a 3.5 NC balloon. Ostium was plied. This is the final result. So we finished the procedure with a 90 ml of contrast. After 2 hours, he was off inotropes. Serum creatinine worsened to 1.6 from 1.2, but got stabilized then. And urine output was good, and stayed in ICU for 3 days, and LV function improved to 45 to 50%, and we were able to discharge on 7th day. So ECG 3 weeks later was showing this LA rhythm. I suggested Imholter, but they told that they are not willing. So limitation was that there is only 1 stent from left main to LAD, no 2 stents because of the financial constraints. No I was in my lab. IABP and TPI could have been used. LMC occlusion, usually catastrophic, can present as cardiac death, cardiogenic shock, pump failure, and this fellow was lucky enough to survive even after diagnosis, even though they delayed the procedure. So single stent is the simplest of the technique, and we can adopt a single stent when there is no major impact on LCX ostium, as in this case the size is less than 2 mm. Ostium of Circ was not involved, and it was non-dominant. Thank you.
I think this is very true that under acute setting, just fix left main LAD and everything is taken care of. Don't worry about circumflex. I mean, I wouldn't even have wired the circumflex to begin with. We had to ultimately take it off.
Not wired circumflex. Wired, first wire went into diagonal. It was not moving into LAD, so I put second wire and put into LAD. It was not going into LAD.
I thought you were trying wire and second was in circumflex. No.
No.
Okay. We need to move fast for the NIC presentation. Thank you indeed, Dr. Vishwanath. Next we go to